Okay, so one more MLA condition series. It won't be the last one for you, but it's the last one for me. So we're going to look at peripheral nerve problems. So median nerve, you'll know this as carpal tunnel syndrome. So the median nerve supplies most of the muscles of the forearm at the front, the anterior, and carpal tunnel syndrome, it causes numbness, pain or weakness due to compression of the median nerve. And I've got a nice little diagram here. So median nerve is pink, so it's these areas here. So the 4 2 fingers, a little bit of the ring finger and the thumb. Now, the median nerve passes through the carpal tunnel, which is a little sort of bony canal. Remember as well that in men and women, the nerve is probably about the same diameter. So women have a smaller wrist, they have a smaller canal. So particularly when women have any cause of swelling of general structures, so in pregnancy or if they have hypothyroidism, that can precipitate carpal tunnel due to swelling, then narrowing that canal and causing compression of the median nerve. Other things that can help you diagnose median nerve palsy: Phelan's test, so forced wrist flexion, that can bring on the symptoms of the tingling and the numbness. People also talk about the tingling and numbness happening at night, and they wring out their hands. They call it the hand ring sign, and that's really quite diagnostic. If people do that, they almost always have carpal nerve problems. And nerve conduction studies can help us diagnose how serious this is, and they may need carpal tunnel release. If somebody has medium to severe compression, you want to release that, because otherwise they will lose function in these key structures. So the 4 2 fingers and the thumb pretty much give you your hand function. They give you pincer grip, they allow you to use cutlery, they allow you to feed yourself, they allow you to write. If you lose this function, your hand is largely useless. And for milder carpal tunnel, you can use wrist splints or steroid injections. So ulnar nerve palsy quite commonly occurs at the elbow, where you have a cubital tunnel. That's your funny bone, so it's not fully enclosed. So if you hit your ulnar nerve at that exposed point, you then get numbness and tingling along the ulnar distribution of the nerve, which is the outer part of the ring finger, the little finger, and the lateral part of the hand going up to the elbow on the inner aspect. You can get weakness and wasting of the ring finger and the little finger, which can curl in, and that can give you this claw hand. And that can also cause weakness of some thumb movements and the interossei, which allow you to move your fingers in and out. And that could also be easily detected on nerve conduction studies. Radial nerve palsies are less common, but we do see them in two particular situations. So the Saturday night palsy, which everyone has heard of, and I will just go out of shot and grab a spare chair, and that's where somebody's had a bit too much to drink, and they lean on a chair and fall asleep when they're a bit drunk, and then they compress their radial nerve at the axilla, and then they wake up the next morning and they have a wrist drop because of the compression of the radial nerve at that point. Also, if you have a fracture of your proximal humerus, you can get damage to the radial nerve on the radial groove. You can cause damage to the radial nerve in that way. Wrist drop from a Saturday night palsy has a pretty good prognosis. It tends to recover after a few weeks. If you have a fracture, it depends on the level of trauma really as to what level of recovery you can have. Moving on to the legs. So a foot drop is something that we see quite often as neurologists, and it can be caused by a number of different conditions. We worry about spinal pathology. It can be a presenting complaint in motor neuron disease, but more commonly it can be caused by perineal nerve palsy or common perineal nerve palsy. And that's where the common perineal nerve that lifts up the foot and everts the foot as well, everts the ankle, is a bit exposed at the head of the fibula. And if you get injury there, or if you cross your legs a lot, or if you lose a lot of weight, you can cause damage there and give you a foot drop. Now, strawberry picker's foot is a really, really old name for it, but in Finland, back in the 60s and 70s, people used to take breaks from school and they used to squat down and go into the strawberry fields and pick, all the school children, and quite a lot of the school children then would develop floppy feet because they would cause damage to their common perineal nerve by picking strawberries. Much more common for us is we see people who maybe have surgery and they may be in a sort of surgical brackets, and they can have damage there. But we do see it most often from a combination of weight loss and leg crossing, or sometimes kneeling, and that's called carpet layer's foot. Sensory loss is variable. You can get some sensory loss over the dorsum of the great toe and over the lateral side of the leg. Nerve conduction studies can be done if the history isn't compelling or you're not quite sure, but physiotherapy and orthotics is what you would use, and quite often can have very good recovery. Sciatic nerve palsy, so this is an enormous nerve, and it arises from L4 to S3 nerve roots. And if you damage the sciatic nerve, it's usually trauma after hip surgery, or sometimes from an injection which goes to medial instead of lateral. And if you have significant damage to the sciatic nerve which doesn't recover, that can give you quite a devastating injury. It gives you like a flail foot, where the whole of the lower part of the leg really doesn't work and is just very floppy. But you would know that that's distinct from a common perineal nerve palsy because you've got more extensive weakness. So it wouldn't just be in dorsiflexion of the foot and eversion of the ankle. You would also have it from a number of other movements would be affected. You can get bilateral sciatic nerve palsies, which can cause quite significant disability of both legs. The most common situation I see bilateral sciatic nerve palsies is when people who are immobile get stuck on the toilet, and then they get pressure put on both sciatic nerves, and then they can have paralysis of the legs afterwards. Sometimes that recovers quite well if people aren't stuck for quite some time, but it's worth thinking about when people come in with a long lie, stuck on the toilet, raised CK. If they have weak legs, consider bilateral sciatic nerve palsy. And that's it. Thank you.